everybody here okay? Okay, good. I'm Dr. Emily Dakin, and I am a professor in the social work department. I teach a course on aging, a course on death and dying, and so I'm kind of like the resident gerontologist in our department. And I'm going to just provide a little bit of background context that will then get sort of fleshed out with presentations that follow. Feel free to interrupt me at any time with a question or a comment so that this can be kind of an engaged conversation with one another. Okay. Slideshow, right? Again, yes. Okay. Okay. An introductory quote that I came across that I thought would be that I thought was really helpful for setting the stage. This is a quote that's from our textbook, and says the idea that you and I should have the final say did not gather force until our society started a renewed dialogue about dying and death, stimulated by the increasingly widespread application of life support systems and the emergence of the hospice care movement. Patient self-determination had to overcome the habit of leaving such matters to the medical system. And that quote, I think, is a nice encapsulation of the various factors that have led us to where we are here today and having a conversation like this. Okay, so we're going to talk about some of the different factors that have brought us to this discussion today. So the first is hospice as a movement. There are origins of the hospice movement that go significantly far back in human history, but more recently, the modern emergence of the hospice movement began with the establishment of a hospice called St. Christopher's in London. And the person who created that was really remarkable woman. She was a physician, nurse, and social worker. So she was kind of represented most of the hospice care team in one person. And then hospice then moved over to the US, and the first hospice program in the US began in Connecticut, the Connecticut Hospice in New Haven, and that began in 1974. So there are certain things that you see as part of the hospice movement. A hallmark of hospice is its focus on comfort care, or what we call palliative care. So historically, medicine and healthcare have been focused on curing patients. Whereas with the hospice movement, we start to focus not on curing patients, but rather on providing comfort, which is what we call palliative care. And with hospice, we focus on pain as a type of comfort that is addressed, also difficulties breathing, and nausea as some of the topics that are addressed. Okay, so one of the reasons that this is relevant to us is, one, it's addressing end of life care, so it's bringing that into the conversation. And two, it is focused on the needs and desires of the patient. So we start seeing this focus on what does the patient want. This is a perspective that hasn't been really a priority in healthcare as much in the past. Okay, another factor has been medical technology. So medical technology in the form of life support and life-saving or preserving measures like CPR have raised questions that didn't used to exist. So we have one of the key issues in bioethics has been the development of technology that develops more quickly than society is able to develop legal and ethical responses to those technologies. So now we have this ability to keep people alive, and there can be these ambiguous questions like, is this person really alive or dead? It can be a bit unclear. And so the ability to keep someone alive on life support or prevent an otherwise certain death have created the opportunity for people to voice their preferences ahead of time if if that person is in an ambiguous state where they're facing a certain death that could possibly be prevented, or they find themselves in a state where it's kind of unclear if they're really alive or not. And I'd also say a general trend that we're seeing in healthcare, this is kind of like one manifestation is advanced care planning. But overall in healthcare, we're seeing this movement away from a model where the physician is making all decisions and into a model that is more collaborative based on decision making with the client. And part of this is that we can see optimized healthcare options when a patient feels a sense of self-efficacy. Self-efficacy refers to this idea that somebody has power and the control, they're able to have an impact on their situation. So if the patient is like a collaborative presence within the healthcare team, they're going to have better outcomes. They're going to feel a sense of empowerment. So this brings us to the topic of advanced directives and living wills. If we go back to this previous slide, I think also some other trends that relate to this. One is the advent of the internet and Google. So you've probably heard people talk about like Dr. Google. So now people can sort of engage with the healthcare system with a greater sense of expertise than in the past, where they are not so much like passive recipients of knowledge, but and for better or worse, like there's some good aspects and some negative aspects about people being able to do a lot of research on their own about health issues. But I think the internet is another factor in this. And I think, another factor is that in the past, the physician was sort of had like a godlike status in the healthcare field. What the physician said is just sort of what happened. And I think there's a degree of leveling out of some of the different professions where there's more collaboration across the professions as well. And I think that has also contributed to there being an overall more collaborative approach to patient care. Okay, so this brings us to the topic of advanced directives. So an advanced directive is an instruction for actions to be taken in the future if one is unable to speak for oneself at that time in the future. And the living will was the first advanced directive to receive general attention in the US. And it was created in 1968. So it was very much ahead of its time. And it was the first type of advanced directive. But it was of some limit, it had some limitations. So one of the limitations was that it didn't provide a lot of specificity about how specific choices that a person would like to have made. And the second was that, like any kind of advanced directive, is of limited use if healthcare providers are not aware of it and it's not integrated into the healthcare system. So that could be another issue, is somebody might have a living will, but it might not be something that people are aware of or know where to find or how to find it. Okay, any questions or any comments on this before we turn it over to the more specific discussions. Yes. Yeah. 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 And yeah, so now if people are coming in and they're like, hey, I gotta say, I'm an intelligent person. I can understand things. I don't have to just have these people telling me. I can make some choices for myself. Mhm. Mhm. Yeah, yeah. So that makes me think of just two other things that I'll touch on really quickly is the field of bioethics is a relatively new field. And that introduced this idea that there are ethical ideas in healthcare, and one of those is self-determination. So that certainly fits closely within this. Self-determination says people have a right to make decisions for themselves about what their choices are, their preferences are. And so having an awareness of like ethical concepts related to healthcare. And then a final thing that I don't know why I didn't think about this, but another factor about why we're here having discussions like this is the field of thanatology. This is the study of death and looking at death from a sociological perspective and talking about death. Um, we are now having we've traditionally been a death phobic society. People don't talk about death. There hasn't been space to talk about it. So um in I'd say the latter half of the 20th century till now, there's been starting to open the door to people being able to talk about this topic. And that also has, I think, led us to this place of having documents, being able to make choices and know about options. Okay, so I will turn it over to Amber.
Thank you, Emily. Hello, everybody. Just give me a moment to switch PowerPoints here. Not sure how to exit. Oh, here we go. Okay, so my name is Amber Moody Dyer, and I'm a medical social worker with the Borum Hospice and Palliative Care. And I have Hannah, one of our other social workers, handing out these slides. If you're like me, I'm a frenetic note taker and I like to take notes. So I always try to bring my PowerPoint slide handouts when I present if anybody else wants to take notes or write questions as we go along. But I'm happy to answer questions too as I go. Just raise your hand so I can see you. I've been with Amorum for about 4 years now and done a lot of other things in social work before that, but absolutely love the work that I do now with hospice and palliative care. A big part of the social worker's role in hospice and palliative care is helping patients and families with advanced care planning and advanced directives. But I want to say something about that. It doesn't matter what age you are, whether you're sick or not, these are important things to do as soon as you become an adult. Because we don't know what's going to happen to us. We're not promised the next day. Anybody can get in an accident. Anybody can have a health emergency or crisis, and perhaps at whatever age not be able to make their own decisions and find them in that themselves in that situation. So I think it's good to do advanced care planning as soon as you're capable of doing it and making your own decisions and signing paperwork and all that good stuff. I'm going to talk about a lot of different documents, a lot of different acronyms like DNRO, MOST, HCPOA, POA, all that stuff, and what the differences are and kind of how they work. But before we even get to all that, the starting place of this is to kind of explore and know your own personal beliefs and values. What makes a meaningful quality life for you and for your loved ones? Because those feelings and values and decisions oftentimes guide people to make, check the boxes on the forms and make decisions about what they want their code status to be in certain situations. And I'll talk about what that means. So really exploring your beliefs and values. And I have put out on the desk out there, hopefully y'all grabbed one, and I have an extra in case I ran out. This is the book that we use with patients and families. It's provided by the Carolinas Center, which is kind of our regional hub for hospice and palliative care resources. And it's called Isn't It Time We Talk? A Family Guide to Healthcare Decision Making. And it's really good because it kind of helps families and people get at that issue of what their underlying values are. What does quality of life mean? Is quality or quantity of life more important? And at the back of this, there's a couple things inserted in there. One of them is the document that we use as a joint living will and healthcare power of attorney document. So you're welcome to take that with you and use it. There are other versions out there in the world that are valid, but this is the one that we developed. And I'll talk about kind of the logistics of the forms here in a little bit, but definitely take a look at this later on and try to answer some of those questions for yourself, because I think sometimes they're kind of difficult questions that we have to think on for a while before we know the answers to them. It's also really important to know your healthcare options and know your healthcare situation, because the example that the woman gave here about her mother not even knowing, like no one saying the word cancer to her. I mean, we have to know those things to be able to make the right decisions for ourselves. So, and a lot of times, even though it's better now, you're right, it's better. You would be surprised at how many times I sit down with a patient getting admitted into hospice and no one has told them that they're dying. And it's very frustrating because, sometimes maybe no one has said it. Sometimes maybe no one has said it in a way they've understood and made sure they understood. And there is such things as denial too, but we still have a long way to go as far as communicating, the medical field communicating healthcare to patients and making sure that they're understanding kind of where they're at. So having discussions with family, with your primary care physician, with your specialist, whatever that may be on the particular issue is really important. And I always think it's a really good idea if you're the one who's sick or your loved one is sick, take somebody with you, because sometimes it's hard to be your own advocate and to think of all the questions that you want to ask, but having another person there to really help do that in the moment can be helpful. And then we get to completing the advanced directives and the paperwork and all of that fun stuff. And then we have to make sure we communicate what we decide and what we say on those advanced directives to the people that will ultimately be making those decisions. So that's kind of the step-by-step process. It's not necessarily just completing the paperwork. So advanced directives are legal documents. There's different kind of requirements for them, but essentially they're ways to retain and maintain control over your own healthcare decisions, to prepare for a time, and not everyone will get to this time, where you're still alive potentially, but not able to make your own decisions anymore. That can happen for a lot of different reasons. A lot of different diseases can progress to a point where people aren't able to cognitively say what they want and make those difficult decisions. But I will say this, you do advance directives to plan for that time, but you are always a decision maker until the point where you can't do that anymore. So even though you may do a healthcare power of attorney or a do not resuscitate order, a doctor should always ask you, as long as you're able to make that decision, what do you want to do? Here's the information. Here's the options. So you're going to be the decision maker until you can't be anymore, even if you fill out that paperwork. And these are essentially instructions for doctors, the medical field, and family members to make those decisions when you become unable. So as I mentioned, there are a few, and I'll get into that, examples of ways that advanced directives can be done, even when people they don't have capacity to make decisions themselves. They can be done by family members, next of kin, that kind of thing. But it's always good to do it yourself because you're the one who knows what you really want, and do it ahead of time. And then, of course, you know, the reason that people have to have capacity is that these forms have to be signed and notarized. And appointing someone to be your healthcare agent is what you're trying to do to make these decisions before you get to the point where you can. Yeah, go ahead. Oh, I see what you're saying. I thought you were saying like if people can write or indicate. So there are situations where people aren't verbal, but they're still competent. But yes, I mean, you're still, if you do these ahead of time, you've essentially become your own decision maker, even though you get to a point where you're not able to. Now, there is a little bit of an exception to that, which I can talk more about. There is a place on most living wills and healthcare power of attorney documents where you can say, in the event that my living will and my healthcare power of attorney conflict, I want you to follow this person, or I want you to follow this living will. And there are advantages and disadvantages of picking either one of those, which we can get into for sure. So capacity and competency, it can be tricky sometimes, right? I mean, maybe you all have had loved ones that have experienced dementia, Parkinson's, Alzheimer's. There's a progression. You know, people can have that diagnosis initially in the early stages and still have capacity to make decisions. So essentially it's defined as, you know, can you kind of weigh out the facts and consider different options? You know, it starts oftentimes, like if I'm asked to do a healthcare power of attorney for somebody, I will ask real basic questions, you know, like, can you tell me the date? What's your birthday? Who's the president? You know, that kind of stuff. But sometimes people can answer some questions like that. But when it gets into making complex decisions, people may just say, I don't know, I don't understand, you know, because there's a sort of a continuum. So, you know, you know, it's important to do it when you're fully of sound mind and there's really no question about your capacity. So let's talk about living wills and healthcare powers of attorney. So in that packet that I was referring to, there is an example of a living will and a healthcare power of attorney. The living will is, and I get this a lot too, and it makes sense because they kind of have the same name. There's a will, and then there's a living will. So sometimes when I ask people, do you have a living will? They'll say, well, yeah, I'm leaving this to this person and this to this person. And I say, well, no, that's a little different. That's your financial kind of estate planning will. A living will is really about medical decisions that, you know, what types of interventions that you would or wouldn't want in certain situations. It's essentially a legal document that allows you to die a natural death, right? Without a bunch of interventions, machines, and all of those types of things. Oftentimes, you know, people may make a decision about that in one state. Maybe you're healthy, you're well, and you say, well, yeah, I want people to do everything. Like, what if I get into a car accident and maybe I just need a little time on a ventilator and then I can bounce back? Or what if I get COVID and I just need a little time on a ventilator and I can bounce back? But most of the folks that I work with have a terminal incurable diagnosis. So there's going to be a decline, right? And there's no cure for it. However, you know, that doesn't preclude their right to receive CPR and be on a ventilator and every type of intervention to keep them alive for as long as possible, if that's what they want. But I would say 90% of the time, people in the situation of having a terminal illness choose to do this. They choose to say, I don't want extraordinary measures to keep me alive. I don't want CPR performed if my heart stops naturally, or if my organs shut down, those types of things. So a living will simply, in our version, it gives 3 different scenarios, but it boils down to, I'm not going to be cured. I have a terminal diagnosis and I don't want life prolonging measures done. Now, what that does not mean is people are just going to let you suffer. No, not at all. It's about comfort and quality of life. There's lots of things that can be done to make people comfortable. In fact, a lot of the things that keep people alive, machines, make people more uncomfortable. So it's by doing the living will, you're not saying you don't want medicine or you don't want to be kept comfortable. You're just saying you don't want these aggressive kind of life prolonging measures, things like being put on a ventilator. Yeah, go ahead. It's pretty recognized, but I would definitely say if you have specific things in mind, there are places where you can stipulate that. For example, in this living will that's in the back of your packet, there's a place where people can say, even though I don't, I'm saying I don't want my life prolonged in these situations, I do want tube feeding. So people can say they want that, and also say that they don't want life prolonging measures. Now, I will say this about that. I'm from the Midwest. I don't know where everybody's from originally. How many of you are from the South? Okay. There is something about the South and food. There just is. And it's like people struggle so much because with a lot of advanced illnesses, people lose their appetite and they stop eating very much. And sometimes they stop eating completely. And sometimes they get to the point where they literally can't swallow anymore. And family members, more than patients, struggle with that. They're like, I'm starving my mom, I'm starving my dad. But, and it is someone's right. It is a family member's right if they're that healthcare power of attorney and the patient can't make those decisions to say, I want tube feeding, I want my family member to be kept alive as long as possible. There are a lot of complications that can introduce medically, especially when people are in the dying process. So it's important to know that. A lot of times bodies that are dying and transitioning kind of know how to take care of themselves. And when you introduce things like that, it creates risks for infection. The body's not able to absorb the nutrients. So it can create a lot of complications. But that is one of the things I see folks struggle with a lot. So we definitely allow people to say if they still want tube feeding, but we try to provide education about why that can be complicated too, and how it can actually prolong suffering at times, because it may extend life a little bit in those instances, but it can also create a lot of discomfort that then has to be managed. There's also, I've seen, this is another example. I didn't make copies because this is proprietary. It costs money and we don't own it. It's called 5 Wishes. Have y'all heard of that? It has a living will and healthcare power of attorney section in it also. And there are lots of blanks. So you can get real specific about what you do and don't want done. And sometimes somebody, I've had people say before, do CPR one time, and if it brings me back, great. And if it doesn't, then stop. And we'll write that on the document, or yeah, put me on a ventilator, but I don't want to be on there for like longer than a few weeks if, it doesn't look like I'm going to come back. And we'll write that on there. So you can get specific if you want to about things. Absolutely. Yeah, go ahead. Say again. It is essentially a type of living will. Yeah, there's lots of different formats out there. So the 5 Wishes gets into, I really like this document. It's just not one that we use. Like I said, it does cost money, but you can order it online. And a lot of times like senior centers will have them available or hospitals will have them available, like the hospital social worker. But I think it's the 4th and the 5th wish are trying to figure out what are the actual parts. One of the wishes specifically speaks to the healthcare power of attorney, like who you want to appoint to that. And then one speaks to, you know, what kinds of life prolonging treatments you do or don't want. And then the other ones are really, that's wish two, actually. The other ones are really neat because they get really specific about, you know, if I'm dying, I want music played. I want someone to hold my hand, like really personal stuff, and really specific to help family members, help facilities, help agencies that maybe like us that may be working with you know what kind of environment to create for people. That is their direction. It's their decision. So it's a really cool document for sure. I just couldn't make copies with you all for you all, but there are places to get them. So any other questions before I move on to healthcare power of attorney? Okay, and we'll have time for questions in the end too. So as I said before, your healthcare power of attorney allows you to name a healthcare agent. You can name somebody and then you can name a backup person if something were to happen to that person, and then you don't have to redo it if your healthcare agent is unavailable for some reason. It has to be an adult, and it has to be someone that you trust, obviously, right? You want this person to follow your wishes. I definitely have worked with people that have said, yes, my wife, husband is my next of kin, but I want this child or my sister or my friend to be my healthcare power of attorney. That's okay. I mean, that might be a hard discussion to have with your spouse, right? But you can choose anybody. It doesn't have to be your next of kin. It doesn't have to be a relative. And even though you do it ahead of time when you're of sound mind, it doesn't take effect. It sort of lies in wait, I like to tell people, until you are unable to make your own decisions. So we're always going to ask you until you're unable to answer. And then we'll go to your healthcare power of attorney. And that person is going to be able to direct your medical care, hire and fire medical providers on your behalf, consent or refuse to tests or treatments. And this is going to require 2 signatures, right? So a notary has to watch you sign the document, and 2 witnesses have to sign it as well. And I am a notary as well, just so we can help our patients and families in that way. And I always tell people, the witnesses, it's better if they really have no, they can't be related to you, but it's better if they have kind of no stake or no real knowledge of your situation, because they're literally just people to witness the signature. That's it. And we actually can't be witnesses as healthcare providers. So you know, sometimes we use neighbors. Sometimes if we're at the hospital, we'll use other patient family members. I know the Project on Aging has provided volunteers to serve as witnesses before for folks. So folks from church, you know, just that type of thing. So here's the other really interesting thing. If I go and I do a healthcare power of attorney for Heather, and she names someone, and I have 2 witnesses, the person that she names as her healthcare power of attorney doesn't have to be present. So it's really important that you talk to your chosen healthcare power of attorney and tell them, hey, I made you my healthcare power of attorney, and that this is what that means. And this is what I would want in certain situations. And here's a copy of it. And here's a copy of my living will, and really get into that with them. You want this person to, you know, they're going to be able to access your medical records. They're going to be able to direct disposition of your body. So like if you want to be cremated, if you want to donate your body to science, that type of thing. So you really want this person to be somebody who will honor your wishes. And as I was saying before, you can pick on the living will. You can say, in the event that these 2 things conflict, I want you to follow the advice of my healthcare power of attorney. The advantage to that is we can't always anticipate every medical scenario, right? We can think through some things, but maybe something happens and the healthcare power of attorney is like, maybe you have, you know, you want no life prolonging anything, but the healthcare power of attorney has some information that makes them feel like there might be a chance, or, you know, something you didn't anticipate. So that's an advantage of giving that person that authority over your living will. At the same time, there's a little bit of a disadvantage because a lot of times healthcare powers of attorney are family members, are loved ones for us. And things can get tough, right? When you're with a spouse or a parent or a family member and you're making these decisions, even if you know what they want or they told you what they want, people can get scared, they can get worried, they can change their mind and try to keep you around longer maybe than you'd want. And so that's the advantage of saying, no, follow my living will, not my healthcare power of attorney. So it's just one of those things you have to kind of decide, depending on who your healthcare power of attorney is, kind of which way you want to go with that. And I kind of talked about this as well. Make sure you give copies of your documents to your healthcare agent, but also to your primary physician, or if you're seeing a specialist like an oncologist or something like that, and make sure they know kind of who your decision maker is. And we always definitely get copies of those things for hospice and palliative care too. So we know who to listen to if our patients aren't able to communicate with us anymore. A lot of times people will say, oh yeah, I'm a healthcare power of attorney, or healthcare agent, the decision maker, but no actual formal document's been done. In those situations, and it definitely happens, there are still options. There is North Carolina statute, which directs us as to kind of the order of operations for who we listen to in the event that there is no healthcare power of attorney. If someone has a court-appointed guardian, that's kind of at the top of the list. If there's no healthcare agent, then it's the spouse. If there's no spouse, then it's the majority of adult children and living parents. And that can get a little bit dicey because sometimes people can disagree. And if there are no children or parents, then it's siblings. And if there are no siblings, then it's any interested person that's acting on your behalf, essentially. You know, I've had an uncle, I've had a good friend be in that role. And if there is literally no one like that, it's essentially the physician that's directing your care at that point. So that's why it's really good if you can to kind of lay this stuff out ahead of time. So you can get documents notarized in a lot of places these days, banks, lawyers' offices. Although if you go through a lawyer's office to do this, it's probably going to cost some money. We provide the service free to our patients and families, but a lot of times if you can get a hold of a document like the one I gave you, you can take it to the bank and they can notarize it for you. Just make sure that you don't sign it ahead of time, because that's part of the notary has to witness you sign it and the witnesses have to witness you signing it. Local government offices, notaries do typically charge a small fee, maybe like $5 or $10. I mean, I don't even know, because I don't charge a fee for my services with our patients and families, but just kind of be prepared for that. Keep that in mind. I think a lot of banks, like if it's your bank, they'll do things like that for free. There are a couple other ways. As I mentioned, before I get to that, you can change this. I always tell people, as long as you're still able to make decisions, you can do a healthcare power of attorney and a living will. And 2 years from now, you're still able to make your own decisions. You can change it. You just rip it up and we'll do a new one. You know, you can cancel them at any time. Just throw them in the trash. And make sure you tell anybody you gave them to, your doctor or anything like that, this is no longer valid. So stuff isn't set in stone. Things can change over time that affect your decision. But it's always good to kind of get a jump on it. And then as something changes, just redo it and make sure everything's kind of up to date. Okay, these are the things I wanted to talk about that don't require people to be of sound mind. And that next of kin can sign off on, or family members. So a DNRO stands for Do Not Resuscitate Order. And that is really important in the medical field. So one of the first questions that we make sure we know the answer to for our patients and families that we serve is, and this is the way I always explain it to people, if your heart were to stop and you were to stop breathing, so essentially that's, you've died essentially. Do you want cardiopulmonary resuscitation performed? Do you want chest compressions to bring you back to life, right? That is what a DNRO speaks to. That is all it speaks to. It doesn't speak to IV fluids. It doesn't speak to your comfort. If you're going through an illness or a dying process, it is literally about whether you want CPR performed in the event that your heart stops and you stop breathing. And I'll say, 9 times out of 10, most of our patients do either already have a DNR or want a DNR because they're saying, I've got less than 6 months to live essentially. So why would I want to go through that and end up in a worse off situation than I am now or on a ventilator? But also we have patients that say, I want to be here every stinking second that I can. I love this life. I love my family. I don't want to leave them. I will be here and be miserable if I have to be. And I respect both those decisions because they both make sense to me on some level. So that is always a person's right, whether they're on hospice or not, to have a DNR. You can, when you're of sound mind, get one for yourself and let people know and let your doctor know. But also, even if you're not, a family member could do that for you. And sometimes, there just wasn't planning done. And a child or a spouse will say, I know this is not what they'd want, so let's go ahead and get a DNRO. The thing about the DNRO is a physician has to sign it. It has to be signed by a physician. And it's kind of a medical order, essentially. A MOST form is similar, but really more specific. It stands for Medical Orders for Scope of Treatment. Every state has a different version of this form. In North Carolina, it's a MOST form, and it's bright pink. I brought an example of that too, but we didn't have too many at the office. I had to get them to get more, so I couldn't bring a bunch. But you can get this from your doctor's office. People do not have to be, like I said, of sound mind. The patient doesn't have to sign this document. The patient can sign the document if they are of sound mind, but a family member can also sign it. A physician also has to sign this document. It is a medical order. And it speaks to CPR, right? Whether you want a resuscitation attempted or not. It also speaks to whether you would want a full scope of treatment, intubation, mechanical ventilation, or maybe limited interventions. That's kind of the mid-level. So that's like, well, I may want IV fluids, maybe a BiPAP, a CPAP, less invasive airway support than a ventilator. Maybe send me to the hospital if I'm declining. But I don't want CPR. I don't want to be on a ventilator. And then the last choice is comfort measures. So that's, keep me clean, warm, and dry. Use medication by any route, but no extraordinary measures. Don't transfer me to the hospital unless my comfort needs can't be met at home. And we also ask about antibiotics, whether people want antibiotics or not, whether they want IV fluids, a feeding tube. And that's pretty much it. That's what's on a MOST form. So that's another way this can be done. Say, for example, if a living will never got done and somebody is not able to make their own decisions anymore. Yeah. Yes. I'm so glad you asked that. That's still a question that's up in the air in my experience. There might be somebody who could speak to that more specifically, but I have been told both by EMS professionals. So what I always tell patients is, we're going to get you a DNR in your house. I always say it's bright yellow. It's the goldenrod. This is what it looks like. And this, I say, put it on your fridge, put it where everybody knows it is, because sometimes somebody's with the patient and maybe the patient becomes unconscious. Maybe it's a family member, a neighbor, and they panic and they call 911 instead of calling us. And EMS gets there. If they don't see this document, they are legally obligated to perform like every possible intervention in that moment to keep someone alive. Someone could be telling them like, no, they have a DNR order. Where is it? We actually had a patient in transit in an ambulance once. The family had forgotten to send the DNR with them, and the patient started to go into distress. and the EMS drivers called us and said, what's this person's code status? And we were able to tell, we have copies of these things too. So, so it's really important to put these in a very prominent place. If you or a loved one gets transported to the hospital via EMS, to send that with them. And the most form, I have had EMS people tell me that they will honor that, but I've also had situations where that didn't happen. So I always encourage people, if they want to have a do not resuscitate order, to get the goldenrod as well as the most form. Just cover your bases. That's a pretty major thing to get messed up. So cover your bases. It won't hurt to have both, for sure. Yeah. Yes, they absolutely would. They would do everything possible. CPR, ventilator, everything possible. If they didn't have any instructions, that's what our healthcare providers are legally obligated to do. It's not. It's a good way to, if you don't want certain things done, like if you don't want IV fluids, or it's really used a lot in hospitals. So for example, if your loved one goes to hospital and maybe they are transitioning, right? And they have, they might have a DNR, but the doctors need to know how people feel about IV fluids. They need to make sure people are on the same page about not wanting a feeding tube, antibiotics, things that could extend life for periods of time, but also could extend suffering in the event that the person is actually transitioning. So it gets specific, like past the DNR, the code order, essentially. It gets more specific about levels of interventions. And it's especially helpful if someone doesn't have a living will, because and they can't make their decisions any longer. But it isn't necessarily a required thing, no. Yeah. Mhm. Mhm. Tell me the first part of that question again, because I'm not quite understanding. Just tell me again what you were asking. Mm-hmm. 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 Yeah, and that's your right. Once you get the more information. Yes, absolutely. Yeah. And I think you know, that makes total sense to me. What we always try to do, and we do this as a medical team, because I'm not a nurse, I'm not a doctor, I'm a medical social worker, but we try to provide education to people about CPR. And so absolutely people have the right to have that performed, even if they are dying, but even if they're older, even if they're, for any reason. And, of course, like outcomes are different for different people, for young people versus older people versus terminally ill people versus frail people. You all saw the football player. I don't know if you heard about that, the football player that they performed CPR. And this young, like as healthy as a person could be. And he didn't do too good there for a while. Like he was requiring oxygen for a while after that. But he's doing great. He's doing a lot better now. So that's excellent. Sometimes, the realities of CPR, especially as we age and our bones change and things like that. I like to make people aware that it will likely crush ribs. It could, do a lot of damage, because it is a very, I watched my first code this past year on a patient. It's a very violent process on a body. So but I've also had patients that have come back from that. So I think people have the right to make that decision, and everybody kind of weighs their own values and beliefs to make that decision. And it's perfectly understandable for anyone to want CPR to be performed, to want to have at least resuscitation attempted and see. I had one patient tell me one time, well, he said, I mean, what's the risk? I'm going to be dead if I don't do it. So why not try it? I was like, that's a really good point. So we don't try to pressure people either way. We just try to provide the education and the training that we've been provided so they can make the most informed decision possible. Sorry, I'm going long, but real quick, I think this might be one of my last 2 slides. Oh, it's my last slide. All right. A couple other things. I've kind of explained the difference between a living will and a will. We do perform or complete what's called a simple will for patients when they request it and notarize it. And that is just, I want to leave everything that I own to one person. We will do that for our patients. But anytime it gets more complicated than that, we always recommend people go to a lawyer if you want to divide up assets, that type of thing. And obviously we do living wills because that's a healthcare directive. There's some differences between a durable or financial POA and a healthcare POA. Your durable or financial POA, I've heard it referred to interchangeably. That is giving someone power over your finances, essentially. And one thing that's, that can be necessary for a lot of different reasons. You also have to be of sound mind to make that decision. It requires a notary. One thing that's different is as soon as you do it, it takes effect, even if you're of sound mind. That person has a right to do whatever you give them the right to do. You can specify certain examples with your finances. So just keep that in mind. And that is typically something that's good to talk to a lawyer about if you're getting into that kind of a situation. Once someone loses capacity to do that, the only real way to sort of gain controls over someone's finances is to apply to be a guardian. And that's a whole other process. So it is nice when people have the ability to do this ahead of time when they know they're going to decline and may not be able to manage bills and things like that. So that is another kind of advanced directive. It's just not necessarily a healthcare directive. So that's all I got. Does anybody have any other questions before Heather comes up? Yeah. Ooh, that's probably outside my ability to answer. What I tell people when people ask me questions like that is anybody can sue anybody for anything. If you can find a lawyer that'll do it, and so, I've also had situations. I have had medical professionals tell me that a person can sue them, a living will can't. I have ethical issues with that. But for example, if someone has a living will that says, I don't want any of these things done, but they have a spouse or somebody there that's saying, you better do this or I'm going to sue you, it's hard to know what's going to happen in that situation. So it's always good when you have a healthcare power of attorney that can follow that living will. And so if there's some kind of errant person, family member that we love, but maybe is a little bit too aggressive about trying to do something against our wishes, that doctor has a healthcare power of attorney and a living will they can follow. But I always tell people anybody can sue anybody else for anything. Now, whether or not you can win a lawsuit is another question. So, but that is definitely a good question for a lawyer, not me. Any other questions? All right, Heather, close us out. I'll bring your PowerPoint up for you. How about that? Do this one right. Let me get all my papers out of the way. You just click on that a little quicker. Yes, I don't know. You want it? Oh, sorry.
I just want to say thank you to everybody who's here today, and I know you're here for different reasons. Some of you are professionals, and some of you are here because you want to make some plans, and some of you are here. I think all the information that both Emily and Amber have given us. I'm imagining in this room, there's people who have had death and loss. And some people have gone through hospice and it's been a great experience. And some people haven't. Some people have been in the hospital and they've had people die in the hospital. So I know in this room, there's lots of experiences of how your relationship to death and to loss. And so I'm going to talk a little bit about grief and loss and some supports related to that. And I'm also going to talk about disenfranchised grief. So I wanted to talk some about formal, informal, and internal resources. When we think about formal resources, and this is after somebody has died. So some of the, and I think I'll say something about myself a little bit first. I've had lots of loss in my life, and I've gotten to the other side of it using lots of these supports. And so I kind of think of myself as a death activist or a death warrior, because I like to I like to talk about it. I like to have the time to support people, but also encourage them to have these conversations like Amber was saying, and think about these conversations ahead of time. So in terms of this piece though, what kind of things can you do? And probably in this room, you have done some of these things for formal support groups. I know I have gone to a grief support group that was put on by a hospice here in town. And it wasn't a hospice that I had used. And Amber, is that how it is now still? Right, so that's a resource. Actually, I went to one in Winston-Salem and I went to one here in town. Sometimes there's grief groups through people's religious affiliations, or people have the contact with their pastor, or sometimes there's a team that helps people with those kind of things. There are grief counselors. There are counselors who just do mental health counseling, who you can go to for grief counseling. But there are also particular thanatologists. I think one of you said about a thanatologist. And sometimes there's just community groups related to. Even though I'm kind of like a love-hate person with online groups, I do think it has opened up resources for people who aren't able to go to don't have the transportation to go to some of these places. There are online grief support groups, and for very specific things, like people who have lost a child, or people who have lost a spouse, or all those different particular kinds of grief. I know that a lot of times, and I'm imagining people in this room have this experience too, that when you're grieving, the people you want to be around really are people who are grieving, because they really know what you're going through, even if it's not the same kind of a loss. In terms of informal supports, that's more of your friends and your family. A lot of books can provide support to people. I did do some writing groups at the Winston-Salem Hospice when I was going through my own things. So I think all those different things can be supports. What's challenging, and again, those of you who have had loss as well, know that sometimes friends don't know how to talk about it, and family maybe doesn't know how to talk about it. And they often can say things that are very, very actually hurtful. And so that can be challenging. So it's important to find friends that you can talk about it, and whether they've lost people or not. And then internal, what kind of resources do you have yourself? What kind of resources? And these are things that we build through our life. And just a reminder to work on your thoughts and keep your body strong and your spiritual practices strong. Because those are the things that carry people through as they're going through a hard time. I'm actually gonna talk about this one next. So disenfranchised grief is grief that's not openly acknowledged, socially accepted, or publicly mourned. People think of some of those. What are some examples of? Yes. Yes, yes. So expectations of how people should show that. What else? What are some other grief that's not openly acknowledged, socially accepted? Death by suicide can definitely be one of those. It seems like we're talking a little bit more of it, but I think people often shy away from interacting with people. They don't know what to say. Here. Anybody else? What are some other ones you can think of that? Yes, that's, the other one is pregnancy loss. That's one that happens. And what about pets? I think we have ways that our pets can be like our children or our family, especially if our other family members aren't here anymore. So, any other ones you can think about? Yeah. 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 That can definitely be a time when you stories happen. Stories happen. Yeah. Yes. Yes. That's true because people can have what we call chosen family too, and those relationships actually can be closer to than the ones that you have with your biological family. And I think some of those issues of loss too, not just in terms of death, but losses. It could be estrangement from family members. There could be all kinds of other losses that aren't necessarily death. And what do we do with that? Because they can feel like a death. Exactly. Those are other losses. That's right. Divorce. Yeah, that's a good one. Say it again. Loss of job. Yes. All of those. And we don't really have some of those. I guess we have rituals around and we have celebrations or rituals, but not always. Not always. So what suggestions do you have for honor? So okay, we have funerals and we have different rituals or celebrations or times of marking a transition. But what are some other ways that we can honor not just the ones that we see as the traditional losses, but what about these, specifically these disenfranchised grief? What are some ways either you yourself or of that you can honor some of these transitions or changes? What else have you yourself done that doesn't look like a traditional funeral? Mhm. Yeah, come back. That's true. Yes. Yeah. And sometimes people will put together a little kind of a special place in their house that they might light a candle. That could be another thing. A lot of times people do art, some kind of an art project around their to honor the person. Yeah. Some people get tattoos. Yes, that is a way. I've seen people with dates and that's the person's date of their birth probably. So any other ways of honoring people? Right. Yeah, I see you because I think people can feel really invisible and uh-huh. I love it. I love it. That's great. Yeah. Mhm. Yeah. You know, a lot of times people also come, they'll come and they'll bring food for about 2 weeks. And my sister always, one of my sisters says, but what about after lasagna? Which is the, after, going on after that. I think somebody, oh yeah, yes, writing. Yeah, yeah, I've done a lot of that too. Yeah. Yeah, that's a great idea. That's a great idea. I know people do that. That helps them kind of live on, I think. Um, so any other ones? I mean, I know we can have all kinds of ones. So anybody else want to add? Yeah. Oh, oh, that's so creative. Yeah. Death is such a time of disruption too, that it's like, why not do that? It's like you're so, out of our traditional way that why not do something creative or do something fun or donate money? Yeah. Yeah. I my mother died when I was 21, and there were a group of women who had early mother loss, and we would go on Mother's Day every single year and have brunch. And we would go around the table and say to each other, like stories about our moms. We'd go around, and we did that every year for years and years and years. So the next thing I wanted to tell you about is Deaf Cafe. It sounds really strange, but Deaf Cafe, and I can read it to you here. It's strangers gather together, and they say cafe because you have cake and coffee with it. But and the objective is to increase awareness of death with a view to helping people make the most of their finite lives. And when we were talking just a second ago about people not really knowing what to say, this is why I'm a big advocate of this too, is to have these conversations so it's not so awkward to talk about it. The group has no agenda, objectives or themes. It's a discussion group. It's not really grief support. This is actually something you could do now. And it's not really counseling. And you also come there, and I'm going to tell you the story about the one that's here in town. They're a not-for-profit, this is in general. It's accessible, respectful, and confidential. And it's a community conversation, basically. So in 2004, a man named Bernard Pratatz, he was a sociologist and an anthropologist in Switzerland, started this idea. It wasn't called Deaf Cafe at this point, but then it came to the United States in 2011. And the first one was in Columbus, Ohio, and there are 83, it's in 83 countries right now, Deaf Cafe. And there's only one thing that again, it's not really supposed to be educational. You're just supposed to come there as yourself. So if you were a lawyer and you came there, you would be coming as a community member. If you were a social worker, you would just be coming as a community member. And only one question is asked: what brought you to Deaf Cafe? And so there is a Deaf Cafe that happens in town, and I'll tell you the story because Amber and I started it here in town. We had both come to the concept of Deaf Cafe independently, and we were talking about it, and we were like, let's start one in Boone. And then we were like, maybe we should go to one first before we started. So we went to Asheville, and there was Deaf Cafe there, had been going on for years, and there were 55 people at it. And that group broke into small groups of 4 or 5 people. And the only question that was asked was, what brought you to Deaf Cafe? And from that question, each person says their name and then what brought you to Deaf Cafe. And then people talk about all kinds of topics. So I might throw out a topic like, Amber can help me remember some of the amazing conversations we've had. We've had 7 generations at one time there. The college students all the way into the 80s. We've talked about different death rituals in different cultures. We've talked about if you dream of a person who has died. We talk about not just death, but we talk about loss, like some of the losses, this disenfranchised grief, loss of your own traditions, or loss of abilities, or loss of health. So they've been really, really rich conversations, and sometimes we are quiet because somebody is just kind of thinking about what it is that they want to be talking about. Do you want to add anything else about any specific things we've talked about? Oh, yeah. Yeah. It happens, well, let me tell you, it happens now online. We were doing it in a third place and we were actually having cake and coffee, but now we're doing it online because of the COVID. And now we have people who are regular attendees, like one woman she joins us from Oregon. So we've been having it and it's the second Sunday of the month from 3 to 5. It's on Zoom and if you're on Facebook, it's High Country Deaf Cafe. And if you're not, you can tell me at the end and I'll send you an email. I got people who aren't on Facebook. It's a 2-hour time frame. That's correct. Yeah. Anybody's. It's not attached to a specific person who died. What it's attached to is us having a conversation about death and grief and loss. So when we encounter other people who are having that, we can have some familiarity and some comfort in talking about those issues. There's the theory is that we're really not comfortable. We're all gonna die. We're all gonna die and we're all gonna have loved ones who die, but we're not comfortable talking about it. And that would help us live our best lives is the idea, if we can talk about those kind of hard issues. It's 3 to 5. So that's coming up this Sunday. Want to join us? That's right. So you'll be at home anyway. Any other questions? That's the end of my piece. But any questions for me or Amber or Emily? Or comments, questions or comments? So part of what has been interesting for me is just looking into different practices around death. Like there's such thing as a death doula, like a birth doula. That's something that I've looked into. And there's also I've looked into ways of, and we've talked about this in our group, like different ways of burial. So whether you want to do a natural burial and its impact on the environment, that's another thing that we've done, talked about in our group. So yes. Mhm. Friend of mine, her mother died and she was living in Asheville and donated her body to ETSU. And they had her body for 3 years. It's a length of time, yeah. But I think they say it's up to 3 years, right? Any other questions? Thank you so much for being here and asking your questions and being present to this topic.
You don't mind just filling out that evaluation form on your way out. There are extras as you walk out the door as well. And we will post this recording on our website. And I think I have emails for each of you, so I'll send that to you if you need it. And please come back to some of our other engagements we have. The next one is March 10th. So I think that there's a flyer that you might have received as well that has that information on there. Thank you.